You're listening to an Airwave Media Podcast.
I am a scientist. I am a scientist. I am a scientist. We gotta live on science alone.
Welcome to Unbiased Science, where we bring scientific method to the madness. We're your hosts, Dr. Jessica Steyer
and Dr. Andrea Love.
And this week, we are going to tackle a topic that is extremely important. Andrea and I are extremely open and vocal about our mental health issues, and we feel like it's really important to bring awareness to topics that relate to mental health, address and try to remove stigma associated with diagnoses and treatments. And so today we're specifically going to talk about postpartum depression. And we have brought on a very special guest. And I know we say that often, but really today's guest is someone who we met in person, I guess it was a couple of months ago now, at an event that had to do with science communication. And we just completely fell in love with him and his heart and his spirit. Dr. Craig Chepke, thank you so much for joining us today.
Thank you so much for having me. And I'd say the feeling is mutual. I fell in love with y'all's hearts and spirits as well, and your intellects, most importantly.
Oh my God, stop it. Can we clone you? All right. So let me read your bio, your very impressive bio, so folks know who you are. So Dr. Craig Chepke is a board certified psychiatrist and has been named a distinguished fellow of the American Psychiatric Association. He attended NYU School of Medicine and completed his residency training at Duke University. In addition to his clinical practice, Dr. Chepke is an adjunct associate professor of psychiatry for Atrium Health. Dr. Chepke has special interests in treatment-resistant and severe mental illness, movement disorders, and sleep medicine. His approach is to personalize treatment to each individual person, from the newest leading-edge medications to older, underutilized treatments such as lithium and clozapine. Am I saying that correctly? I hope. So, okay. He also strongly emphasizes psychotherapeutic interventions and physical health and wellness through exercise, dietary modification, and supplementation. He is active in clinical trials and serves on the board of directors of nonprofit organizations benefiting schizophrenia and Huntington's disease. Again, Craig, if it's okay, we'll call you Craig during the episode.
Please do, yeah.
We are so happy you're joining us today. Again, thank you.
So obviously you have a lot of expertise in a variety of mental health related conditions, but when we were having dinner, when we first met, we started talking about depression and bipolar disorder, and that led into this conversation about postpartum depression and this newly approved medication. And, you basically revealed to us that you've been very heavily involved in women's mental health care, particularly regarding postpartum depression. And we knew that you were the perfect person to help us tackle this topic. So, let's maybe kick off with a very quick summary. So postpartum depression is a serious clinical mood disorder. It can affect up to 1 in 7 women after giving birth. But there's a lot of confusion and maybe misconceptions about what really is postpartum depression as it is differentiated from other types of maybe mood changes or even major depressive disorder. So Craig, can you kind of walk us through how would one differentiate postpartum depression from maybe the baby blues and even, other sorts of clinical depressive disorders?
Yeah, there is a lot of, one could say controversy or misunderstanding, confusion really around the topic in general. And one thing is that we can define it different ways. There is a perinatal depression, and that's kind of an umbrella that encompasses both the antenatal depression, so if someone gets pregnant or is pregnant and gets depressed during that time frame, and then postpartum depression. And so sometimes those are looked at differently. So the baby blues that you mentioned, that is extremely common. So it's about 75% of women will have something like the baby blues or a postpartum anxiety, that sort of thing. But the critical factor is that the baby blues resolves within 1 to 2 weeks, and it is never associated with severe symptoms. So if someone is having symptoms of the clinical depression, as many people say, after a 2-week period, or if it's within 2 weeks, but these are severe symptoms, well, right then and there, it kind of gets upgraded to a postpartum depression or postpartum anxiety. So in terms of the definition, though, there's even some disagreement there amongst the standardized governing bodies. So the American Psychiatric Association defines peripartum depression as occurring at any time during pregnancy or up to 4 weeks postpartum. Now, why 4 weeks postpartum is a kind of a mystery to me. It seems pretty arbitrary. It doesn't seem biologically based in any way, just that in general, we think in terms of weeks and months as humans instead of defining scientifically what it actually should be. Especially contrasted against the World Health Organization. They define it as starting at birth and then going through 12 months postpartum. And then ACOG, the American College of Obstetrician and Gynecology, they have the broadest definition, which is anytime during pregnancy up to that 12 months postpartum. So not even the major bodies who are really dealing with how to define different diagnoses have any sort of alignment really on what the diagnostic criteria are for the time frame at the very least. One thing that I'll point out, though, is that some claims data have shown that the average time it takes from birth of the child to the diagnosis of postpartum depression is 4 months. So not the 4 weeks that the APA gives. So the APA would say, oh, no, no longer postpartum depression. If it's 5 weeks after birth, can't have anything to do with being postpartum, which I think is rather silly. The DSM has a lot of different problems, and this is one of them. Also, in terms of the DSM, the Diagnostic and Statistical Manual, which is produced by the American Psychiatric Association and used to define all psychiatric diagnoses from our field's perspective, then there actually is no such entity as postpartum depression. It's actually is considered major depressive disorder and has a specifier with postpartum onset. And there are other specifiers like with anxious distress, with seasonal onset, and with melancholic features, and so on and so forth. So it actually doesn't even get its own diagnosis in the DSM, which again leads to some confusion. How important is it per the APA if it's not even getting its own diagnosis separately? It's just a little add-on appendix to the major depressive disorder diagnosis, which I think is a shame because a major depressive disorder is already a mess diagnostically.
Right.
You have to meet 5 out of 9 diagnostic criteria, which mathematically gives you 227 different combinations of symptoms to get one diagnosis. Clearly, we're just not smart enough to figure out what the different subtypes are. But pretty clearly, I think the evidence in neurobiology show that postpartum depression is a fairly reliable subtype that seems quite distinct biologically.
That's such an interesting point. And so some of those symptoms that you might find with, a broader major depressive disorder, but occurring after childbirth, a lot of those, feeling anxious, feeling angry, unprompted, the lack of enthusiasm or interest or emotion for activities that you previously did enjoy, lack of connection or interest in caring for your new baby, crying for no reason and unprompted, and of course, a lot of the insomnia-related symptoms that are often associated with depression, kind of that apathetic, don't really know what to decide on, don't really have strong feelings one way or the other about things that impact your daily life, and often you can see either under-eating or overeating as well. Are there any other symptoms in postpartum depression that you might include there that maybe differentiate beyond just, the timing of onset? You
kind of nailed the list of the symptoms there, and it really highlights you can have overeating or undereating. You can have too much sleep or not enough sleep. You can have it's such a broad diagnosis that, as I said, 227 different combinations. And so really postpartum, you can cover any sort of depression with that.
Yeah.
In fact, the diagnostic criteria for major depressive episodes in bipolar disorder are the exact same as in the traditional unipolar major depressive disorder. Yeah. So it's such a broad category anyway that you really could capture virtually any sort of depressive disorder within that very big tent that they've defined it as.
Yeah.
That's the unfortunate part.
And it's challenging, right? I mean, I personally have major depressive disorder, and my brother had bipolar, and, most of his life before he died by suicide, he was manic. But when he had depressive episodes, they were, the symptoms were very similar, but from an outsider looking in, someone who personally experienced it, in many ways, his seemed to be even more severe or like more extreme. So certainly there's a lot of variability in symptom presentation. And with postpartum, you have to account for these really, really dramatic hormonal changes, right? You have all of these hormones that are preparing your body to, you have been preparing your body to grow another human being and then prepare to deliver that human being. And then afterwards, you have a very rapid shift to a whole different set of hormones for lactation and so on and so forth. And that's not even mentioning a lot of the psychosocial factors. And I know, Jess, you wanted to add something here.
Well, I do. I know it's, Andrew, you're creating a perfect segue into really trying to understand some of the underlying mechanisms and, risk factors. And I think we should definitely go there next. I guess, Craig, I'm sure we have a lot of people listening. I have 2 kids, and I remember when my group of girlfriends and we all kind of had babies around the same time, and we all dealt with new motherhood differently. We experienced different things. But I think what was the statistic that one of you presented? It was like over 75% of women experience, there's something, baby blues, there's something that's going on after we have a child. This is a major, major physical, emotional, mental change in our lives. At what point, and I know we're sort of saying it's difficult to tease out, but is there some indicator of when a mom should reach out for clinical help? Is there some red flag that it's okay, no, this is different. We really need to reach out and get some help here.
So I'm going to answer that. But first, I want to ask you a quick question, Jess. Were you ever screened for postpartum depression after either of your kids?
I was, yes. Anytime I took the kids, there were questionnaires that were handed to me in paper form at the pediatric visits when I would take the kids for their, the shots in the first few months. Yeah. They didn't tell me that's what they were screening for, but putting on my my scientist researcher hat, they were asking questions about, I think it was screening me for depressive symptoms.
That's awesome because, virtually always when I ask women that question, the answer is no one ever screened me for it. And that's the sad part, is that the women fall through the cracks because there's so many different groups that are healthcare professionals who a woman who's just given birth is interfacing with. There's the OBGYN prior to the delivery and up to delivery, and maybe a visit or so afterwards. That if they do have a mental health professional they're already seeing, there is the pediatrician, and then also a primary care provider. So with 4 different sets of healthcare professionals, at least, you would think that it would be very hard to miss a diagnosis of postpartum depression. But it's hard to find something that you're not really looking for. And that's why 70 to 80 cases of postpartum depression go undiagnosed. And obviously, if it goes undiagnosed, it goes untreated. Because I think it's like a game of hot potato that the OBGYN thinks that psych is going to do it. Psych is thinking OBGYN is going to do it. They think PCP is doing it. And everyone is thinking someone else is going to do the screening, and no one does it in many cases. And so the vast majority of women, when I ask that question, they'll say, oh, no, actually, no one ever asked me anything like that. So really, the burden should fall upon the healthcare professionals. In any depressive screening tool can work for it, but there's one specifically developed and validated for postpartum depression called the EPDS, the Edinburgh Postnatal Depression Scale. And it's a really nice one. Honestly, the way the questions are written, I sometimes want to just use it for even women who are not postpartum, because it's a nicely written scale. It also has a little mini anxiety screener in there because it asks several questions about anxiety and rumination, things of that nature. So, but whatever scale it is, something should be done. But as a fallback, obviously, then women unfortunately often have to advocate for themselves with any form of their own health. And so the severity is one marker that I mentioned, that if someone is having really profound symptoms, not able to get out of bed, not able to take care of themselves, let alone the baby. And look, let's face it, it's not like a woman who's just given birth most of the time is only taking care of that brand new baby. Most of the time, what I've seen is that the woman is still responsible for running the household, taking care of the other kids, sometimes still working even. And so it's just a crushing burden that's on most women who have given birth. And that's even without postpartum depression.
Yeah.
You add PPD in there, and my gosh, I mean, I can't imagine how much suffering that this illness can create. So if someone's falling down in that ability to be able to meet those potentially unrealistic demands, then reaching out. But that's the difficult thing. And I know one of you mentioned stigma earlier on is that, I mean, I have 4 kids, and so my wife shares with me some things that she gets from the mommy forums and on Facebook or whatever on social media. And really, literally any decision a new mother makes is wrong by at least 50% of other moms who are on these forums.
Yep,
It doesn't matter
terrible
what.
mother, and you're screwing your kid up for life. Yep,
Completely. Yeah, totally. It could be that, I gave my kid a bath today. Do you know baths are the leading cause of mental illness later in life and will cause autism and or whatever
and
it is?
what are the ingredients in the shampoo and the soap that you're using? And every single thing. Right. Totally.
That's not deuterated water that you're using, right? I mean, or is it alkaline water you're bathing the child in?
Water.
I mean,
it's
Hope there's no fluoride in that water.
Exactly. Right. Exactly. See, just right off the bat, we came up with like 7 controversies that every individual woman is supposed to have the solution for as a new mom. And so to be able to admit, hey, I'm actually not enjoying my time with the baby. I'm not sure if I can take care of this baby. I mean, how's a new mom supposed to say that to anybody?
There's so much,
whether it's a friend, someone on social media, or to a healthcare provider. I mean, so it's all internalized. And so breaking that stigma that it is okay. This is a neurobiological, physiological disorder. And it is for the best interest of the mom, the child, the other children, the entire family unit. That's the main thing. So if anybody out there listening is in this position or knows someone who's in that position, a friend, a family, loved one, whatever, then please encourage them to reach out. Any sort of struggling, because it never hurts to ask. That if you don't know if it's something that is normal or abnormal, talk to a healthcare professional. Because that's literally our job, is to assess it and educate you on what we think is the likelihood of it being something normal or abnormal.
Well, Craig, I love that you say that because, obviously for new moms, there's all this societal pressure and judgment, but just for humans in general, right? Like I remember that when I officially got diagnosed with depression, I was a graduate student and I had a friend who was a medical student because I taught the clinical microbiology. So I met a lot of the med students and he was doing his psych rotation and he was like, you have 8 out of the 9 criteria. And I was like, oh, it's just grad school. Grad school is really stressful and it's really hard. And my PI, it's been tough and blah, blah, blah.
Yeah.
Like just making excuses for it and not, oh yeah, maybe it shouldn't be this hard to like get through the day and get out of bed and brush my teeth and take a shower and all of that. So, I think it is so important to have these these conversations on a broader scale for everyone, but especially women who already have kind of the weight of societal expectations on them.
And I just want to add, Craig, you make such an important point about, seeking help, but there's no easy solution to this. Obviously our healthcare system has some major problems. So I just want to acknowledge that there are probably some people listening who struggle with access to care or making an appointment, or maybe they can't arrange childcare and then, schedule an appointment with a provider. So we just want to acknowledge that, yes, we're saying seek care, but it's not always that easy. So just wanted to point that out.
Absolutely. The social determinants of health are just really critically important to acknowledge here. That you're exactly right. Not everyone has good access to care, period. And those same sorts of social determinants are risk factors for the development of postpartum depression. So people with lower socioeconomic status, people of color have more risk, single mothers, basically any and all of the social determinants of health are substantial risk factors for the development of postpartum depression. Also, intimate partner violence is also a significant risk factor. There's so many risk factors that also prevent people from seeking care. And then, as you said, systematically, in many ways, our healthcare system is quite broken. And so it is a very uphill challenge for anyone who's trying to seek help.
So you beat us to the punch because you already started talking about some of these risk factors and underlying events and circumstances that can lead to someone to develop postpartum depression. But, I'll quickly kind of summarize some and then hand it over to you, Craig, to elaborate. But of course, there's hormonal changes. We know hormones have a huge impact on biology, whether or not we fully understand the scope of everything that they're doing, because there's a lot of biological redundancy and crosstalk and complex signaling going on. But we know that those changes do have those consequences. Of course, history of depression, that can predispose someone to either develop or progress, I suppose you could say, to postpartum depression. A lot of these kind of emotional factors that Jess and Craig, you were mentioning. So these feelings of doubt, feelings of judgment, feeling like you're not enough, you're not doing things that are right. Also feelings about the pregnancy itself, right? A lot of people find themselves pregnant where maybe they don't feel like they're equipped to be pregnant, to have a baby, to care for a baby. And there's not always options available to do what you might need to do to take care of your health. Fatigue and all sorts of other things. So lack of sleep, all these other things are kind of this vicious cycle. And then the other, social determinants of health, lifestyle, right? Access to healthcare, lack of community and familial support, isolation. So if you've recently relocated or if you started a new job or you lost a job or all of those sorts of things. And, not to minimize the postpartum depression itself, but it also increases suicidal ideations and risk of suicide for people who are experiencing postpartum as well. So, Craig, maybe you can elaborate on some of these factors and some of the other things that might be important considerations.
Sure, absolutely. There's a bunch that I'd like to highlight or underline there. So, again, postpartum depression is incredibly common. 1 out of 7 to 1 out of 8 women experience it. And that actually makes it the most common complication associated with childbirth. So more than preterm birth, more than gestational diabetes, more than preeclampsia, ones that are taken very seriously, are screened for very vigorously in every person who's pregnant. And unfortunately, postpartum depression is not on average. A history of prior major depressive disorder is a huge risk factor. It increases the risk by about 20-fold. But for about half of women who end up developing postpartum depression, it's their first major depressive episode ever. So it can really happen to anyone. And again, not just the people who were listed in meeting many or most of the risk factors. Any woman, any age, any socioeconomic status, et cetera, there's no discrimination there by the illness itself. And also another factor that I think is really important to mention is that typically the first, if a woman is on antidepressant medication and she finds out she's pregnant, the first thing she typically does is to stop the medication. And that is very understandable, but it turns out not actually in line with, if in most circumstances, the advice of the professionals are. So I'm friends with many of the women who are the founding board members of the ISRP, the International Society for Reproductive Psychiatry. Their website is reproductivepsychiatry.com. And so their recommendations are that it is best to, with some exceptions for certain medications that have a greater risk, that generally it's best to stay on the medications that kept the person well, because the risk of relapse with discontinuation of medications is just extraordinarily high. And that is not a hospitable environment to develop a fetus in and then go on to give birth in, because again, a 20-fold risk of PPD, that's not a great situation.
Wow.
Another interesting fact with that the ISRP taught me, which really kind of blew my mind, is that, there's the pregnancy categories, which have been defunct now for many years, but are still looked at, which are more or less garbage, but they're still often used. And they're unfortunately used, especially in this category, because let's say something was working for someone for a specific antidepressant, but it is a category C in the old nomenclature. which again doesn't mean very much, but the category B might be another medication. A healthcare provider might say, oh, well, let me put them on the safer medication that they've never been on before. Well, number one, you don't know if it's going to work. And why tolerate any risk if you don't know that there's going to be a benefit? Because all of medicine is risk benefit. But then also, even if the second one does work, and even if it is purportedly, quote unquote, safer in pregnancy, you've now exposed that fetus to 2 different medications, not just one. So it would be preferable from their perspective as the experts in this field to stay on the medication that is theoretically, quote unquote, less safe than switching someone to one that's more safe if the first one is working, because one exposure is better than 2. That was a complete mind-blowing moment for me a number of years ago when I learned that, because that, if I was taught anything, which honestly I wasn't really taught a whole lot of this in medical school or training, anything we were kind of taught ad hoc was not that. It was that take them off, put them on the safest medication, so on and so forth.
Wow.
And it's really, there was little to no thought or evidence behind that.
How long ago, sorry, and I'm not trying to make you disclose your age, but how long ago were you in medical school? That's interesting.
So medical school, I finished in 2005 and graduated my psychiatry residency training in 2009. So not that long ago.
I wonder whether, and I don't know that you know the answer to this, but whether that training has sort of evolved and maybe caught up with the evidence. I sure hope so.
But in terms of the pregnancy categories, definitely yes.
Yeah.
And that was roughly around the time that happened. And so we did acknowledge that, but there's a difference between what we acknowledge cognitively and what we actually do when we're found in a certain situation. We revert back as human beings, generally, to what we know and what we're comfortable with. And certainly, I think in the community, there's still a lot of use of that, that old system. But training programs no longer teach that for sure.
So Andrea brought up suicide, and obviously that is something that we certainly hope to avoid. I just wanted to share some statistics here, and then maybe we could talk a bit about suicide among those who suffer from postpartum, and ways that we can, of course, try to avoid. And
maybe before we do that, obviously that can be triggering for people. I lost my brother to suicide. But there is no evidence that talking about suicide increases the likelihood of someone who is experiencing suicidal ideations to actually complete suicide. So talking about it is actually helpful because it can bring awareness to friends and family and loved ones who maybe are not as observant or seeing some of those signs. So that is why we're going to talk about it.
Yeah, thank you for that.
And also not just putting it on the family of being less observant, but also one thing that often happens is that the person who has made the decision to go ahead with a plan for suicide, they feel better because they've reached a decision and they see the light at the end of the tunnel, so to speak. And so it can be very misleading. And the family thinks, oh my gosh, they've turned a corner.
They've pulled themselves out of that cloud. Yeah, for sure.
Oh, wow. And we will, of course, link to some resources in our show notes. Just want to say that as well. Yeah. So up to 20% of postpartum deaths are due to suicide, and suicide during pregnancy and the postpartum period is often attempted through more lethal methods than suicide in the general female population. And of course, I'm sure, we've seen some cases in the news of maternal filicide, which is when a mother kills her child or children due to severe maternal depression within 12 months of delivery. So I think, again, this just really underscores the diagnosis and early intervention for severe postpartum. But Craig, do you want to elaborate on this, or maybe can we talk about this for a little bit?
Sure, absolutely, because it is very important. So, 20% of postpartum deaths are accounted for by suicide, but fortunately, there's not that many postpartum deaths with the healthcare system that we have. So, it is I don't want to scare women out there who might be thinking, "Oh my gosh, what is that? Does that mean there's a 20% chance I'll die by suicide if I have a baby or if I have postpartum depression?" So it is certainly to be taken seriously. But also another factor is that the filicide part, there was actually even recently in the past several months, a pretty high profile case in New York of a reproductive psychiatrist herself who had that happen. And that is much more often associated with postpartum psychosis as opposed to pure postpartum depression. And postpartum psychosis it can come on top of depression, but postpartum psychosis is much more associated with bipolar disorder, actually, and is also much more rare. Postpartum psychosis is much, much more rare as opposed to the 1 out of 7 that may experience postpartum depression. Then somewhere in the range of 1 or 2 out of 1,000 women giving birth could have postpartum psychosis. But it is very striking that, as you mentioned, in terms of suicide, the means do generally tend to be much more lethal by firearm or by another highly lethal means, as opposed to when looking at suicide attempts writ large. Then there's a wide range, and that is really not well understood at all. Why that tends to be the case for women with postpartum psychosis, and why that, or with suicide attempts and postpartum depression. But that's the scary part, is that the attempts are more likely to succeed because they're using more lethal means, sadly. So, but all the more reason that we should be making sure we should be screening for depression in the antenatal period, at birth, and in the postpartum period, to make sure that women who are at risk and who are suffering from postpartum depression are getting recognized and treated.
Yeah.
Because while we can't necessarily prevent all suicides, and I lost my uncle to suicide myself back in 2020, and from major depressive disorder, then we certainly at least have a fighting shot if we are recognizing the illness and we are doing our best to treat the illness.
Yeah, that's a perfect segue, right? We talked about identification, screening, risk factors. So, we know when someone should seek care is ideally it should be kind of ongoing monitored, right? Anytime someone has a baby, they're seeing a healthcare provider, and those, ideally should be getting screened for signs of postpartum depression. And we kind of talked about those. When someone is identified to have postpartum depression, how do we treat that? How do we manage that? I want you to kind of talk about historically and what you found to be most effective, but we do have to talk about the new FDA-approved medication for postpartum depression as well.
You bet. Well, going back historically, it was not a great scenario, because up until 2019, there were no FDA-approved treatments for postpartum depression. And the only treatments that we had at all were the standard antidepressants, the SSRIs, SNRIs, so on and so forth, that were only studied and approved for major depressive disorder. And if those worked phenomenally well for major depressive disorder, maybe that wouldn't be such a bad thing. But there's a lot of issues with just treating regular major depressive disorder with the traditional antidepressants. They have relatively low response and remission rates, and it takes a while for them to work. It's the very frustrating thing, because people don't come in to see a psychiatric provider or to see a primary care provider who's going to treat something psychiatrically. It really almost always until that they're at the end of the rope. They don't come in for early on. Unfortunately, it's usually when they can't take it anymore. They're at risk of losing their job, their marriage, something of that nature, that they need help yesterday. And it's 4 to 6 weeks, 6 to 8 weeks before we can see a benefit most of the time with most of the traditional antidepressants. So especially for, as I mentioned, postpartum depression earlier, that all the compounded pressure on a woman to take care of everything she took care of before she had a baby and a brand new life that is almost completely dependent upon her, 4 to 6 weeks is an eternity. So, of course, because none of the traditional antidepressants are approved, they're all off-label, but that's all we had. So they were used, and then prior to that, the SSRIs, tricyclic antidepressants, et cetera. But in 2019, then there was, I'd say it wouldn't be overselling it to call it really a breakthrough. There was a treatment approved for postpartum depression called, the generic name for it is brexanolone. And brexanolone what's exciting for a number of reasons. One is that it's the first medication approved for a psychiatric indication that was based upon a biological theory. And this goes back to the hormones that were mentioned earlier. And I wanted to kind of delineate that a little bit more. So the two that we think of most often, there's many that change with the pregnancy period and then postpartum. But really the big two are estrogen and progesterone. And they peak going up into the birth, and then they both decline pretty rapidly, really immediately after birth. Estrogen does not have a very strong linkage, though, with postpartum depression. A number of studies have looked at that, and there were not significant differences in overall estrogen levels or the rate of estrogen withdrawal between women with postpartum depression and women who were healthy controls. And because of that, then a lot of research had gone into the progesterone theory. And not necessarily progesterone itself, but a primary active metabolite, which is allopregnanolone. That's the one that was focused on the most in the research. In addition to being a hormone is one word for it, and it's also a neural steroid because it does have effects in neurologically, and it does so through the GABA receptor. So the neurotransmitter GABA is the major inhibitory neurotransmitter in the brain. The major excitatory neurotransmitter in the brain is glutamate. And I think about them, the glutamate and GABA, they're like the Fred and Ginger of the brain. Wherever you find one, you're going to find the other one. And they do a beautiful dance with each other at least when things are going well. But when they get dysregulated, then that is, we believe, to be a source of a lot of problems psychiatrically and neurologically as well. And so allopregnanolone has the ability to activate certain specific GABA receptors. And that's one of the reasons why it was focused on for the development of brexanolone, which is a derivative of allopregnanolone. A lot of great news. It worked very well. It worked very quickly. It is, but the not as great news is that it's a 60-hour IV infusion. So
not feasible for a ton of people. Yeah.
Unfortunately, actually, one of the women I'm friends with who's on the ISRP board, she has done a very extensive use of brexanolone in her practice. But you have to really be very committed to providing it as a treatment because it can't be at home. It has to be in a healthcare setting. Usually that's in a hospital setting. However, my friend, her name is Rachel Dalthorpe. She's a perinatal women's mental health psychiatrist. And so she actually offers it in her clinic. She does have the round-the-clock monitoring with healthcare providers, like with nurses and things like that. She gets a group together, usually on the weekend, of moms who are candidates for it, and they do it two batches, several of them up at a time. So it is possible, but by and large, the most common way in the country to get it is that you have to be admitted to the hospital to do it, unfortunately.
Right.
And that's not optimal for obvious reasons. So while it has, and 60 hours is it. That's all the treatment is. And then it is efficacious in many or most of women who are taking it, and they don't need to continue treatment. It's just the 60 hours and that's it. So that also, unfortunately, it came out later in 2019. And so that ran right up smack into COVID. And that really took the wind out of the even a lot of the centers who had set up to do it initially.
All the resources to deal with, intravenous, medication administration, outpatient, inpatient, you've completely diverted those to dealing with, the next public health crisis.
But on the other hand, though, it's not like we stopped doing chemotherapy during COVID. This women's health treatment is the one that got the resources pulled away from it, which is true. The song remains the same in many ways, that unfortunately women's health and mental health is deprioritized compared to other fields and other genders in many cases, sadly. That's a great point.
So, what you said that remission was very, very high with brexanolone. What percentage was being seen with this, and maybe you can kind of lead us into the new zuranolone, which spoiler, I'm going to spoil it. It's oral. It's not IV. But maybe you can kind of pave the way for that development.
Yeah. So numbers, I don't recall the specific numbers off the top of my head, but they were pretty high for a treatment, which again had no treatments previously that were approved. And if people did get better, then it took weeks to months to do so. So that was really the breakthrough, that it was able to very quickly resolve or at least improve the symptoms for these women, and they could get back to the rest of their lives. But even if there had been no COVID, it's still going to be limited by being 60 hours away from your baby, away from the rest of your life, and things of that nature. So there really did need to be a oral successor to this medication. And the same company who developed the IV version did start work even before that was approved, already on a oral version of it. Again, another derivative of allopregnanolone, and this one was called zuranolone. Is the generic name for it, and that was approved by the FDA back in August of this year. So the trials, the data looked fairly comparable in terms of the ability for it to work quickly and for it to have high rates of response or remission. It's a 14-day course, so instead of 60 hours because IV, it's 100% bioavailability. The oral, because that's actually that I should mention, why not just take oral over-the-counter supplements of allopregnanolone? Those are available at certain places that one can obtain supplements. The problem is that it's virtually negligible bioavailability. So almost none of it actually gets to the after the first pass metabolism, certainly almost none of it gets to the brain. So it's not a potentially effective strategy. So that's why there had to be derivatives of it. And so the zuranolone, its oral bioavailability is much better, and but still it requires 14 days of treatment. But once again, that's it. 14 days of treatment, taking the medication once a day, and that is the entire course. And generally, no other treatment may be required. It's on an individual basis, however. If it's a woman who had major depressive disorder prior to being pregnant and giving birth, then if they were on an antidepressant before, well, they're probably going to be on an antidepressant still to maintain and prevent future episodes. And zuranolone, as approved, can be given either alone or in conjunction with another traditional antidepressant. It was also studied as an accelerator as well. What if you started a new oral antidepressant and zuranolone at the same time? Well, you get a faster response with zuranolone, and then you only take it for 14 days, and you continue on with just the other traditional antidepressant. So it's very versatile in that regard. The benefits started to be seen by day 3, which is actually 48 hours after the first dose. So within 2 days of zuranolone, there started to be measurable and in some cases statistically significant improvements versus placebo. So incredibly different from what we're used to with any other oral antidepressant.
It's incredible, right? The data are striking, and it's really impressive that there are these options that can now help people address postpartum depression. The question that's going to come up, and I'm sure it's coming. So this was approved for postpartum depression. Why can't it be used off-label for major depressive disorder? Why will it not be, or will it be evaluated for major depressive disorder? And I'm pretty sure what you're going to say, but I feel like that's going to be a question that our listeners are going to want answered.
So it's actually even more interesting than that, because not just will it be evaluated for major depressive disorder, it already has been. So the clinical development program was run in parallel with the postpartum depression studies. They were submitted to the FDA at the same time. There were 2 positive trials of zuranolone in standard major depressive disorder, non-peripartum, and it did show benefit. And it submitted to the FDA at the same time, only came out with an approval for postpartum depression, however. So those of us in the psychiatric community were really kind of expecting that it was going to get both FDA approvals. And I was actually listening to your show not too long ago, and there was the hematologist who used to be in the FDA and talked about, and your titles as always are phenomenal. A spoonful of safety makes the medicine go down. That the number one goal of FDA is safety. Efficacy came on later in the mission plan of the FDA, and still efficacy is always important, but safety is the number one priority. Zuranolone was no less safe in major depressive disorder than it was in postpartum depression. However, the efficacy was not as robust. It was there, it was statistically significant, but it was not above the threshold that usually we see in most antidepressants. It used the Hamilton Depression Rating Scale, and usually a 2-point difference between the medication and placebo is kind of considered the floor of what is maybe clinically relevant. And it hit 1.9 in one of the studies difference. Well, A, that's not much different. And B, that's the mean of a large group. Individuals have widely variable responses. And so it's really, to me, quite a shame that we, as a healthcare community, we're not given the ability to use this medication in an on-label fashion, because unfortunately, while the FDA doesn't regulate the practice of medicine, they kind of almost do, because FDA approvals have been weaponized against healthcare providers by managed care. And if something's not FDA approved, it is virtually impossible to get it covered by insurance. And for a new branded medication, whatever it may be, that makes it more or less out of reach for virtually anyone. And so in the midst of a mental health crisis, in a suicide epidemic, to take away a potential tool that could get someone better, possibly within 48 hours, only to have 14 days of treatment at all. I mean, think about how much stigma that could reduce. You don't have to worry about, after 2 weeks, you don't have to worry about someone finding a bottle in your medicine cabinet and saying, "Oh my gosh, what is that? They're taking antidepressants. What does that mean? Is there something wrong with them? Are they crazy, quote unquote?" All the negative stigma that goes along with it that could really have broken down a lot of barriers for people who were afraid of seeking treatment or taking the treatment for a major depressive disorder.
Yeah, or just
that's more or less out of reach for the time being.
For me, I think the thing that's most confounding is the timetable, right? I mean, I've tried, who even knows at this point, all the antidepressants under the sun. Yeah. And, I found one that kind of helps a little bit, but it wasn't until I was diagnosed with ADHD that I was like, oh, well, that makes sense why things weren't working as well as they should. But, people who are in a depressive crisis, they don't necessarily have the patience to wait 6 to 8 weeks to maybe see if that one med is going to have an effect. And then if not, then they have to switch to something else and try again. And it's this mixed bag. Whereas this one, you start to see some benefits in a few days. And by 2 weeks, you can really evaluate, well, is this going to help? Is this not going to help? And so, it does seem, particularly if it's, as safe as the other options, to not have this as a tool in the toolkit, when we know that kind of the world of psychiatric medications are not as cut and dry as, okay, take an antibiotic, your bacterial infection is gone.
Yeah. This is so frustrating.
Yeah,
I'm sorry. No, go on, Craig. You were going to say,
and on a personal note, my uncle that I mentioned took his life in 2020. So he had struggled with MDD his whole life, and he finally found an antidepressant that did work for him. And after some period of time, when he was doing well, he decided, like many people do, that maybe I don't need this anymore. And unfortunately, he did decide to go off of it. And we found that after the fact, 3 days before he took his life, then he did go and refill that medication. But it was too late because it didn't work fast enough.
I'm so sorry.
So if a medication like zuranolone had been available, I mean, no one knows, but if he had seen improvement in that 48-hour period, maybe that would have given him enough hope, a spark of hope to hang on and to stick around. I mean, and how many times does that same scenario potentially play out across this country?
Yeah.
We're seeing record rates of completed suicides per the most recent data that's been released. We're reaching all-time highs almost every year.
Oh my God.
And when a medication that, again, has been shown to be, if it was safe enough for postpartum depression, and there are risks associated with it, to be sure. There's some people can get, there's a box warning for sedation, and there's some restrictions around that. But it's no less safe than it is for postpartum depression.
Right.
The safety and tolerability data were in lockstep, more or less. So if it was safe enough for postpartum depression, it obviously must have been safe enough for overall approval, and not hitting the efficacy criteria that are unwritten, apparently, because we don't actually know what FDA thinks. Even the guest you had some time back said, I'm not there now. I don't know exactly what they're thinking. I can tell you about my experience when I was there.
Right.
So we don't exactly know all their rationales, but it's just really disappointing that not to have that tool and have it more or less taken away from us for the time being.
Yeah,
right.
I'm incensed hearing
That's
this.
what.
Is there? Are we?
I was going to say. I mean, they're probably trying to do a larger cohort or a follow-up study or something. Would be my best estimation, and maybe resubmitting with supplemental data or something like that. Maybe Craig, you can talk about the future direction of some of these indications.
Yeah, so there's actually two companies that have partnered together on the development, and what they've said publicly is that they've not given up on it, and that they are still looking to see what the path forward is. the submissions to the FDA are huge events. I mean, it's upwards of 1 million pages, page equivalents of paper. It's all electronic now, but they're huge amounts of work, and so they're probably conducting other analyses and figuring out, okay, what do we need? They're still probably in discussions with FDA about, well, if we did this, would that be good enough? If we did that, and it's really complicated. And this only happened roughly 3 months ago. So. But like I said, the good news is that they, from what they're saying, are pursuing a potential path forward for it in major depressive disorder for some point in the future.
Craig, thank you so much for everything that you've shared. This is a heavy topic and probably heavier than most of our podcast episodes, but one that is so critically important. And again, we will share resources in our show notes for anyone going through this. And, again, here, Andrea and I, we've been super open about our struggles with depression, anxiety, and other mental health issues. And, it's funny when we share that, people are often like, we never know. And you can be high functioning. You can present as happy and extroverted. That doesn't mean that you're not struggling.
Right, as if there's a scarlet letter
exactly.
of, you look normal, but you have mental health conditions. How can that? Well,
yeah.
People with mental health conditions are normal.
Exactly. And honestly, for those who are watching this on YouTube, you might have seen, as Craig, you were saying some things and I was crying. Honestly, I was sitting over here getting teary-eyed. You're describing that feeling of being at the end of your rope. I mean, unfortunately, so many of us, myself included, have experienced that. And it's really a shame that there is so much stigma, and that especially, on this topic of postpartum depression and women specifically, like it's like things are just, oh, she's overreacting. She's being hysterical, or, oh, she should just deal with it. She's running the household. We have to stop that nonsense. And as you said, I love what you just said. It's normal. It's not, we shouldn't be made to feel like we're abnormal, where we have an issue, just as if we're dealing with a physical illness, right? That needs to be diagnosed and treated. And there should be no stigma with that.
I mean, no one ever says, oh my gosh, you have diabetes. I never would have known.
Exactly. So Craig, any last thoughts? I know we're getting close to wrapping here, Andrew. We'll turn it over to you. But is there anything else that you would like our audience to know, or that you'd like to share with them?
I just believe knowledge is power. And so I mentioned reproductivepsychiatry.com. So for the healthcare professionals who are out there, if you're interested in becoming a member of ISRP. And then one more link that is extremely important that I put out there all the time, womensmentalhealth.org. So that is run by Harvard's Mass General Hospital, and there is the National Pregnancy Registry for various psychotropic medications, so antidepressants, antipsychotics, mood stabilizers, and stimulants. So women can go and register there, and the Mass General will follow them throughout the pregnancy. And that's the only, and also even women who are pregnant who are not on those psychotropic medications, because they need healthy controls as well. And so when they gather enough information on a specific medication on a specific trimester, which with matched controls as well, then they publish that data. So that's the only way we're ever going to get real data on pregnancy, psychotropics in pregnancy. Also, there are educational resources there, both for healthcare providers and for patients. And so really, it's a phenomenal resource for anyone. And again, that's womensmentalhealth.org. It's really something that certainly every healthcare provider should know about, and I think more of the general population should know about as well.
I love that. Thank you, Craig, and we of course will also link those in the show notes of the episode. And I love your little plug for participating in clinical research. Yes, even if you're not on medication, they always need healthy control. So if you're pregnant and you want to be a piece of data, check it out, and we'll link that. Craig, I can't thank you enough. Obviously, we've talked about a lot of these topics before, but it's so great to be able to share this really, really important information with our listeners. And thanks for giving everyone your time today. Thank you, everyone, for tuning in. And we hope you learned a thing or two. We're pretty sure you did. And if you want to support our efforts and help us grow the impact and reach of Unbiased Science, feel free to support us in whatever way you deem fit. You can send us a donation on our website through our Venmo account. You can pick up some science-themed merch on our website. That's www.unbiasedscipod.com. And we do have our biweekly newsletter on Substack, which is theunbiasedscipod.substack.com. Make sure to subscribe to our YouTube because we're recording our beautiful faces on YouTube video now, and all of our social handles at Unbiased SciPod. Catch you next time on the pod, your trusted source for no nonsense, just science.